So to start our discussion of neurological vision and hearing assessment, why don't we do a brief review of the neurological system? You remember it's divided into the central nervous system and the peripheral nervous system. The central nervous system, of course, contains the brain and the spinal cord. The brain has the job of, interpreting messages that are coming in from the periphery, um, and then, deciding what to send back out to the periphery. And the spinal cord is that relay center that gets those messages to the brain and sends them back out to the periphery. In the peripheral nervous system, we have the somatic nervous system, and that's those voluntary systems and movement of skeletal muscles, that kind of thing. And the autonomic nervous system that does things like sending signals to the organs and the glands. That's kind of that fight or flight response that everyone kind of talks about. So here's a little picture of the brain, spinal cord, brain and connections to the spinal cord. And this is, of course, again, the central nervous system, brain and spinal cord. The brain is what's responsible for interpreting those signals, things like pain, temperature, and touch, telling us what those mean, giving those just stimuli meaning. The brain has to, be alert and, arousable to be able to process those stimuli. The brain forms memories. It helps us with our coordination and balance. Remember, we talked about the cerebellum is largely responsible for coordination, balance, and posture. It also keeps what we call our equilibrium. And the spinal cord is the relay system between those peripheral nerves, what brings information in from the outside world, and the brain. And it also takes care of reflexes. We'll touch on reflexes briefly, but if you remember, reflexes are just a simple relay center. You have a stimuli that comes in, it goes to the spinal cord, and with no interpretation by the brain or involvement of the brain, a signal goes back out. And we'll talk about that a little more when we get to reflex. And then the peripheral nervous system, you have 12 cranial nerves within the peripheral nervous system that we'll talk about more in depth, and then 31 pairs of spinal nerves. Okay. The spinal nerves sense things like pain, temp, touch, and proprioception. Remember that term, proprioception. And then it relays the messages from the brain for voluntary type movements. So information in, information back out. So mostly today we'll just talk about how do we assess the neurological system? How do we find out if it's working properly? What kind of things do we do? And we'll look at specifically mental status, level of consciousness, motor function, sensory function, reflexes, and cranial nerves. You see the little picture here. Remember, we talked about reflexes. This is a simple depiction of what a reflex would look like. You can see the hammer going in, and that's the stimulus. And the muscle is here, so you hit the tendon, and it stimulates the muscle. And the nerve fibers go from the muscle back just into the spinal cord. And then that's the relay center. The message comes right back out from the spinal cord back to the muscle with no involvement in the brain. So in a mental status assessment, language, orientation, memory, attention span, and calculation are all assessed. Now with language, we're not talking about what language do you speak. We're talking about your ability to express language and your ability for the brain to process language. So can you express yourself, and can you understand what other people are saying to you? The ability to express yourself, if you lose that ability, if you lose the ability to express what you're thinking, that's something called expressive aphasia. So you know what you want to say, you can comprehend what you want to say, you just don't have the ability to say it. Vice versa, if you have a receptive aphasia, you can speak normally and fluently and something that others will understand, but you can't understand what they are saying to you. So understand the differences between receptive and expressive aphasia. and understand what that would look like in a patient. Orientation, again, remember, is that person, place, and time. And we also add that little piece of self here, because you'll see in the readings that orientation to person is not necessarily is not orientation to self. It's orientation to those around you. So we add that little self piece on. Okay. Memory has 3 types of memory: immediate, short-term, and long-term. Remember that immediate recall we assessed by giving someone perhaps a string of 5 numbers and then maybe increasing the amount of numbers to see if they could just, parrot those back to us. Recent memory, remember we assessed by asking maybe what did you have for breakfast or how did you get here? And then those long-term memories, things that happened in the past. Attention span, can someone focus on a task at hand? So do they assess that? We would give them a task and see if they could focus on it. Maybe say the alphabet, which isn't necessarily a difficult task, but requires someone to have an attention span to complete. And then calculation, we use things like serial 7s, or we have here counting backwards from 100. To assess level of consciousness, our most common tool that we use is something called the Glasgow Coma Scale. What we want you to know about the Glasgow Coma Scale is that it has 3 distinct areas. It's really most commonly used in patients who've had some kind of head injury. This isn't a scale I would say we generally use on a normal walking, talking patient coming into a clinic. This would be someone with known head injury that we would generally tend to use this on. So for eye-opening, we would see their best response within each category, and we would score them for that. So if they could only open their eyes to extremely painful stimuli, we'd give them a 2. If they could talk but they were confused, maybe we would give them a 4. And if they could just kind of localize for motor response, we would give them a 5, and we would add those numbers together. 2, 6, 5, and we'd have an 11 would be their Glasgow Coma Scale. Remember that 7 and below is comatose, and there's no 0 on this scale. For motor assessment, we look at 2 different areas. We look at gross motor and fine motor. We can assess someone's gait as they walk across the room. Is it balanced, coordinated, that kind of thing. We can have them walk heel to toe, walk on their toes, walk on their heels, balance on 1 foot. And those are all gross motor assessments. You wouldn't need to do all of those assessments. One would probably tell you what you need to know, whether or not someone has intact gross motor ability. And then in there is that Romberg test. Remember that when we call it a negative test, it's really a normal finding. Negative test means normal finding in the case of a Romberg test. Okay, it means that someone can maintain upright posture even with their eyes closed. So you see this young lady standing here performing a Romberg test. She's maintaining safety by standing close to her client and asking him to close his eyes. He may sway slightly as he first closes his eyes, but that's okay. That's normal. We just don't want him to tip over like this unfortunate gentleman here. And then your fine motor assessments, you can assess fine motor in the upper and lower extremities. Lower extremities, we did some heel to shin, or can you touch your toe to the examiner's finger. And then upper extremity fine motor, can you touch your fingers to your fingers. We often have patients close their eyes, especially these upper extremities, so that the visual system doesn't take over and mask any neurological deficits. Some abnormal results you may see in a motor assessment if someone just loses their balance or if their gait is kind of awkward or uncoordinated. You may see unilateral weakness. It's very common in neurological assessments to be comparing bilaterally. Does the right side look like what the left side is doing? If the right side is vastly different than the left side, we may have some neurological impairment. We may see tremors or slow, imprecise movements, especially with some of those fine motor assessments. In order to assess sensory assessment, We look at things like light touch versus pain, or remember dull versus sharp. Remember, we have a safety pin here. You may use the sharp end and then the dull end and see if a patient can tell the difference. Cotton ball for light touch. The positioning of the fingers and toes depicted here, remember that's that kinesthetic sense. In stereogenesis, remember we had someone hold a key in their hand. They should be able to tell us what it is. Whenever we're doing these sensory tests, we want to make sure, first of all, that the client's eyes are closed, because again, if someone has an impairment neurologically, they may be able to compensate for that using their visual senses. And we want to make sure they're not doing that so that we can fully be assessing the neurological system. And then also remember to test distal areas first. If we're testing the most distal area of a patient, say if, for instance, if we're doing these tests on the legs, if we're testing in the distal areas and we are getting normal findings, we can kind of assume that we'll have normal findings all the way up the leg, and it can shorten the assessment. So start distal, move proximal. Some abnormal findings here: you may have decreased or even increased sensation. You may have someone, when you're doing dull and sharp, who when you use the sharp end of a safety pin, may not be able to feel that as sharp. That would be an abnormal finding. Paresthesias, that's one of a fancy word we use to describe numbness or tingling. Or they may not be able to identify those positionings, or that they may have a kinesthetic problem, or not be able to identify an object. Again, here are the reflexes. We kind of talked about how reflexes work. DTR means deep tendon reflex. This is a pretty common abbreviation that you'll see, DTR. So again, these are unconscious, they're automatic. The brain is not involved in these responses. Now, general practitioners generally don't perform these deep tendon reflexes in a full assessment, and that's what you'll see in your readings as well. But one assessment that we do sometimes perform is the Babinski reflex. So understand the difference between a normal and abnormal Babinski reflex. Most common time you'll perform this assessment is if you're caring for a patient post-stroke, because these patients often display a abnormal Babinski. Also, kind of be comfortable with how reflexes are recorded. It's a 0 to 4 scale, 0 being no reflex at all, and 4 being hyper or maximally active. 2 is a normal finding. Again, you probably won't be charting these necessarily yourself. Babinski is not charted on this scale. Babinski is either positive or negative. But you may see these in neurological charting of somebody else, and it's important to understand what they mean. We'll talk later in the semester about things like electrolytes, and those have some important significance in reflexes, so you want to be comfortable with how they are charted and expressed. And then we'll look at cranial nerves. Remember, we have 12 cranial nerves. They all have a different function, and they're numbered, of course, cranial nerve 1 through 12, and they're also named. So you can see cranial nerve 1, for instance, is our olfactory cranial nerve, and its function is, of course, smell. That's a sensory function. And each cranial nerve either is sensory or motor, or it may be mixed. You'll see here that cranial nerve 3, the main function of that nerve is extraocular movement or eye movement, and also pupillary response. And those are motor functions. So here we have 2 sensory and 1 purely motor cranial nerve. When you're looking at cranial nerves as well, you want to kind of understand, if I was testing that cranial nerve, what tests would I perform? So if we're looking at, again, at the olfactory cranial nerve, we would ask a client to identify common smells with their eyes closed. Again, very important, closed. I'm not going to read through all of these. You have these in your book. You guys have been working quite a bit with cranial nerves. But again, just note that they're numbered and each has its own name, and they're divided into motor. Here you can see that cranial nerve 5, your trigeminal nerve, functions as a mixed cranial nerve, meaning that it has both sensory and motor functions. It is responsible for allowing you to blink, to clench your teeth, and it also gives you sensation in your face. Remember, we used that cotton ball to see if we had light touch sensation of the face. That would assess cranial nerve 5. Here are 2 more mixed cranial nerves. The facial nerve is responsible for taste, so that's a sensory function. And then also some facial expressions, so that's a mixed cranial nerve. Here's another one for taste and swallow. Here's cranial nerve 8. Remember, this is the one that was also associated with the Romberg test because it's responsible for equilibrium. Okay. And then cranial nerve 10, 11, and 12. So it's a good idea to get in your head perhaps a mnemonic that'll help you maybe remember your cranial nerves. Here's one that'll give you that uses the names of all the cranial nerves on Old Olympus Towering Top. There's lots of them out there. You can Google them. Find one that kind of sticks in your head if this one doesn't work for you. On this side, some say Merry Money, but my brother says Bad Business, Mary's Money. These help you remember if they're sensory, motor, or both. So there's mnemonics to remember the cranial nerves and mnemonics to remember their functions. We'll also talk about some lifespan considerations, especially in the older adults. That's really the population we're focusing on this semester. It's also a population where you're going to see more neurological impairments. So it's important to understand how you may want to modify that assessment in this population. You may want to take more time with a neurological assessment with an older adult and do it over more sessions to get better results. The older adult may fatigue more easily, especially if they have a neurological impairment. And once a client becomes, fatigued, you may have more of an amplification of neurological deficits that you wouldn't necessarily see if you broke that up into shorter sessions. Learning and intelligence should remain unchanged across the lifespan. It's not normal to have a reduced ability to learn or a reduced intelligence. But there are more factors that may inhibit learning in an older adult, things like anxiety, illness, pain. There's more chronic illness, that kind of thing, as we age that might inhibit learning. Short-term memory may become a little less efficient. They're more prone to stress, depression, fatigue. You may see decreased reflexes in the older adult, and that's normal, and reaction time may slow. We'll touch briefly on the physical assessment of the eye, too. So we're done with the neurological assessment. Now we'll talk about eyes and ears, kind of separately. There, of course, is some overlap here, so we'll touch on that as well. So we can visually inspect the eye. You can use an ophthalmoscope, but again, we as general practitioners don't generally tend to use an ophthalmoscope. That's the device where you shine the light to look deep into the eye. That's not an assessment we would generally perform. We can perform eye inspection just kind of a really general eye inspection, though. We can check the conjunctiva for redness, things like conjunctivitis. So we can look in the eye with our, perhaps with our pen light, just to inspect those structures. Palpation, this is a focused assessment. This is not something we're not going to be palpating or touching eyes. There are some very limited applications to maybe some light touch to the cornea, but that's not something you would generally be doing in a neurological or an eye assessment. Other related tests, we talked about pupillary response. Remember, pupillary response, I believe, is cranial nerve 3 is responsible for that pupillary reaction. There are lots of things that can change pupillary response, things like head trauma, things like drug exposure. So remember, we test the pupils by shining a light into one pupil. We want a darkened room. We bring the light toward the pupil, and when the light hits that pupil, it should constrict, okay? And the pupil that we shine the light into will constrict, and also the opposite pupil will. So for instance, if we shine a light into the left eye, the right pupil should constrict at the same time as the left pupil, okay? And PERLA is really how we chart this. So PERLA stands for pupils are equal, meaning they're the same size. So again, we're comparing bilaterally. Pupils are equal, they're round. We want them to be round. We don't want them to be irregularly shaped. And they react to light, meaning they constrict when light is shined in. And the A stands for accommodation. And accommodation is the term for that pupillary response we see when both pupils constrict in response to light being shown into one eye. So again, accommodation is when the right pupil constricts even when light is being shined into the left eye. So pupils are equal, round, and react to light and accommodation. Other physical assessments we do with the eye, we can check visual acuity. Remember, we do that near vision with a Snellen chart. We can also test for something called presbyopia, which we'll talk about a little bit later. That's that near vision. So that's, can someone, see up close? If I hand them a newspaper, can they read that at a normal reading distance? We did some peripheral vision assessments where we held maybe 2 fingers at the out of someone's vision and had them look straight ahead. We brought those fingers in to see how early someone could sense that those were coming into their peripheral vision. And we also looked at ocular eye movements. We looked at these in conjunction with 3 different cranial nerves. I believe it's 3, 4, and 6 are the 3 cranial nerves responsible for your cardinal fields of gaze. So a normal eye assessment, maybe someone with 20/20 vision. Here's your Snellen chart. Their pupils are equal, round, react to light and accommodation. Their eye movements are coordinated. I don't see any nystagmus. And their peripheral vision is intact. Some abnormal findings, maybe they have some decreased visual acuity, either from the Snellen chart or maybe they can't read that newsprint. Maybe there's a lack of response of one or both pupils, or maybe they're not round, or maybe there's no accommodation. You may see nystagmus as you're checking your cardinal fields of gaze. Your eye movements may not be coordinated, or you may have a decrease in your peripheral vision. So there are several common deviations with the eyes in older adults that you should be aware of. Visual acuity, especially near vision, often decreases as we age. That's that presbyopia, that's near vision. Okay, so that happens. I think the flexibility of the lens itself decreases as we age, so it gets harder and harder to read up close, and then we get these cute reader glasses. The eyelids may start to droop as we lose skin elasticity as we age. Tear production decreases, so dry eye is more common, and peripheral vision often decreases in the older adult. Then just some physical assessment of the ears. Again, we can inspect the inside of the ears with an otoscope, but we as general practitioners don't generally use an otoscope. We can inspect maybe generally, the outside of the ear, but we're probably not going to be looking inside with an otoscope. We can palpate around the ear as well. But more commonly, we maybe do some gross hearing tests. Gross hearing assessment, can someone, hear me if I'm talking in just a conversational tone? If that's normal, I'm probably good to stop there. But if we pick up on hearing acuity problems in a normal conversation, we may do something like the whisper test, where we whisper a word to a patient and see if they can repeat back what we said. And then also remember the Weber and Rene test. The Weber test, where we're testing for that lateralization of sound by activating our tuning fork and kind of putting it in the middle of the head, seeing if that sound traveled equally to both sides or lateralized to one side or the other. And then in the Rene test, we were comparing bone conduction to air conduction. Remember that air conduction hearing should be greater than, or we should hear that longer than we could hear that bone conduction. That would be the normal finding. Here's just a depiction of the ear, middle ear, and inner ear. Don't be too concerned about remembering all those pieces. So in an ear assessment finding, normal findings would be gross hearing would be intact. You'd have negative Weber test, and in your Rene test, you would want air conduction to be longer than bone conduction. So those would be your normal findings. Abnormal, unable to hear ticking clock. That's another way that's a test similar to whispered words test. So if we noted that gross hearing was impaired and we moved on to the whisper ticking clock test, those may be abnormal. Or abnormal Weber test, if the sound from that tuning fork would lateralize to one side or the other, or an abnormal Rene would be if your air conduction was equal to your bone conduction. Again, we'll talk about common deviations with older adults as well. So loss of connective tissue causes the external ear to really be drier and less resilient, and it also causes drier earwax. It's not uncommon in elderly populations for them to get an excess or a buildup of earwax. So sometimes in older adults, and hearing loss may be due to earwax.